Attempt to do in this tape will be the treatment of the head forward posture, other cervical dysfunctions, as well as TMJ disorder and cranial misalignment. For treatment of the head forward posture, a number of muscles we want to work. Sternocleidomastoid, which we've done on the last tape, as well as the scalenes and the longus colli and capitis and the suboccipital muscles. The suboccipital muscles are involved in the head forward posture as a writing mechanism to keep the eyes horizontal with the plane line of vision by shortening and rocking the occiput back on the atlas. They're also responsible for causing migraine headaches when they become hypertonic. To treat the suboccipital muscles, the patient's head will be rotated away from the doctor's hand. You'll make a thumb backed by a crooked index finger contact when you treat. First, you're going to palpate, though, the suboccipital rim, I to S. You'll be palpating the inferior nuchal line and the superior nuchal line. Now, because we're in an area where there's hair, to avoid discomfort to the patient, we'll take one hand on top of the forehead like this, and we'll inhibit the speed and the length of the patient's motion. Once we find a restriction, which I find right here in the suboccipital area, I take that thumb and crooked index finger contact inferior to the lesion. I press P to A and hook up I to S, and then ask the patient slowly to tuck their chin in. As you can see with my superior hand, I'm limiting how much they can move. In fact, it was probably hard to see the patient's head move at all. That's about how much it moved. However, that was enough to get that much more motion. So they don't have to move a whole lot, and this will prevent us from dragging our thumbs through their hair and causing them pain. When we get more lateral to the mastoid process area, not only will they be moving from extension to flexion, but there'll be an ipsilateral to a contralateral flexion component. Right here is we locate a restriction. We go lateral to medial, I to S, beneath the lesion, and I ask the patient now to push their head to the left gently. And we would repeat that several times. If I'm working in the hair, for instance, along the inferior nuchal line, I take again a P to A and I to S contact underneath the bony ridge. I extend the patient's neck and ask her to tuck her chin in. You can see there's very little motion involved, and there's no motion in my thumb whatsoever, so it shouldn't cause any discomfort, even though we're able to get an excellent release like that. We've already done the SCM. The scalenes would be the next muscle we're going to work, along with the longus colli and capitis. These muscles are involved in a lot of symptoms, specifically deep head pain, TMJ pain, as well as contributing greatly to the head forward posture, and also rib subluxations or fixations. For the scalenes, it's important to have the patient's throat relaxed, to let them know that you're going to be working with the trachea, that there may be popping and clicking involved with this technique. They're also lying on the table supine with the legs bent. We're going to recruit the hips with this technique so that we don't have to go quite so deep and risk hurting the patient. We can bring her head a little bit in flexion by having her put her arms crossed behind her head, actually behind the occiput. When she does this, this automatically puts her in a counter-strain position where we're getting a slow stretch on the posterior muscles and a relaxation of the anterior cervical muscles. I'm going to take my thumb and I'm going to palpate along the anterior aspect of the transverse processes, trying to find any restriction in a headward fashion, I to S fashion. If I do, rather than just voluntarily moving her head from flexion extension, I'm going to locate my fingers beneath the lesion and I'll have her begin to shrug her hips. Now I'm going to ask, as you watch her right hip come up, as it does right now, that is now causing a tightening or shortening of muscle on the left side of her neck and a lengthening of muscle on the right side. So as she's bringing her hip up, continue doing that. Right now, the SCM, the scalene lengthens into my fingertips, lengthens again, and usually 6 to 8 of these movements done in a row will be enough to release the scar tissue within the scalene. So when we come back and check, we now have a tremendous release of tissues. This is based on the fact that during ambulation, when the person is contracting the psoas muscle, the contralateral side shortens and the ipsilateral side of the longus colli, capitis, and scalenes lengthens. The longus colli and capitis is very deep. It actually lies anterior to the intervertebral bodies and discs. I would also not hesitate to do this technique for anterior cervical disc pain, which we mentioned on the previous tape, can refer pain into the midscapular region. I'm going to take a thumb contact. I'm going to, after warning the patient what I'm doing, displace the entire trachea to the midline of the chin. Then with my fingers, I go as deep as possible. You can actually feel the intervertebral bodies and discs here, and I'm feeling right along the center of the bodies and discs for restriction, which I encounter here. I take a finger contact beneath that, and again, I ask the patient very gently to begin to shrug the hips. Now watch the right hip. As it comes up as it does now, that's when the ipsilateral longus colli and capitis is lengthening against my contact. Right now it's lengthening, now it contracts away. It lengthens towards, contracts away. Lengthens towards, contracts away. We go ahead and do that again 6 to 8 times per point, come back and check, and we'll find a nice release of tissues here. Perhaps the most important part of the treatment for the head forward posture is actually an exercise the patient will be instructed to do called the 6x6x6 exercise. It's also known as Roccabato's exercise, after Mariano Roccavato, the Chilean physiotherapist who devised this. We can release the anterior cervical muscles, but unless we actually work the bony changes that have occurred due to the head forward posture, muscle changes will be for naught. As the patient's head goes forward, what will happen is the 7th cervical vertebra goes into an extension malposition, while the 1st thoracic vertebra goes into a flexion malposition. This causes an approximation to the spine's processes posteriorly, and it will cause bony changes, proliferative bony changes in this area. So we actually have to somehow reverse that situation where we'll bring repetitively C7 into flexion and T1 into extension, trying to get a head forward posture corrected. The way the exercise is done, I'll have the patient, during the particular treatment session I'm teaching her this, mimic me as I teach her the following exercise. I want the patient's feet shoulder width apart, thumbs are pointing out. I'll ask the patient now to tighten their buttock muscles. As they do that, it begins to bring the pelvis underneath the lumbar spine properly. I'll ask the patient then to bring their thumbs back as if they're trying to touch their shoulder blades together, as far as they'll go. And then I'll ask the patient to tuck their chin in even farther, as if they're looking at their toes. Now they're going to bring their head back over their shoulders in a moment, but they're not going to do it in this fashion. As they do that, they just exaggerate the malposition that already exists. So they continue to have their head pointing down towards the floor, and they'll do a transitory motion in this direction, just like this. I'll usually will stop and tell the patient to feel what I'm doing, so they realize they're only moving the head probably about 1/2 of an inch posteriorly. They'll do that, they'll hold that posture for 6 seconds, and then they'll relax. So we relax posture. When they relax, I ask the patient, did you feel pain anywhere, especially in the rhomboid area? If they have pain, that's a positive rhomboid cramp test. I will treat them for rhomboid trigger points or scar tissue. Same thing if they produce pain in the suboccipitals or the SCM muscles. If they feel pain in the cervicothoracic junction area, which is common, I tell them that's to be expected, it's normal, because they are trying to create ligamentous and bony changes there. If they get any peripheralization of pain, say a week from now, Claudette comes in for another treatment and she says her neck hurts worse, but it's here only in the cervicothoracic junction. That's centralized pain, and we continue to have the patient exercise through that. If they have peripheralized pain, burning in the shoulders, for instance, or pain or numbness down the arms, that's indicative of thoracic outlet syndrome. We would look at the scalenes and the pectoralis major and minor muscle before we continue on with the patient doing that exercise. The name of the exercise comes from the fact that she'll do 6 seconds of exercise 6 times, constituting 1 set, and she'll do 6 sets a day. She'll do the 6 sets until the head forward posture is corrected, namely the zygoma of the maxilla is now over the manubrium of the sternum. When that's corrected, she'll do a 6x6x2 procedure where she's doing the exercise morning and night just to prevent the malpositions from returning. This usually takes up from 4 to 6 months to obtain a full and long-lasting correction. When treating the patient, not for head forward posture, but for hypolordosis of the cervical spine, the same muscles are treated, namely the SCM, scalenes, longus colli capitis, and the suboccipital muscles. The 6x6x6 exercise would be contraindicated for the head forward posture, so we're not going to be doing that. But instead we'll be doing 2 cervical extension exercises, which are designed to help bring the cervical curve back by strengthening the intrinsic muscles of the spine. The first one will be merely cervical extension. The patient will go from the neutral position she's in now to lifting her head in extension and looking up. She does this 15 times, looking up and breathing in. As she's doing this, she's working the multifidi and rotatory muscles, which tend to be paretic or weakened in the average person with hypolordosis. Also, the patient, following spinal manipulation, is now capable of, by doing this exercise, of firing a lot of joint mechanoreceptors, which will further enhance protein replication in these muscles and their strengthening. The patient will do 15 sets 3 times a day until the correction of the cervical curve occurs. The second exercise, which they will do at the same time, will be to come up on the elbows, which now helps to reverse the hyperkyphosis oftentimes associated with the decreased cervical curve. The patient will go only from a neutral position to extension, not from a flexed position to extension. They'll start here and do the same thing, looking up, breathing in, doing this 15 seconds, 3 times. The only person for whom this would be contraindicated would be a low back pain patient who has central canal stenosis, which you would determine from your X-ray readings done on your lateral radiographs. This is also done 15 times, 3 times a day. If the patient has head tilt or head rotation, muscles that are worked will be the SCM, the scalenes, the posterior cervical muscles. If we're treating rotation, if Claudette had right rotation, the muscle that would be treated in the scalenes would be the left-sided SCM. If she had head tilt to the right by itself, we would be treating the right side of the SCM. If she had head tilt and rotation to the right side, we'd be treating the right SCM and the left SCM, the right side for the head tilt, the left side for rotation. Even though we think that these are the principal muscles involved in causing head tilt and head rotation, new research in neurology seems to indicate that actually the ocular muscles of the eye are most responsible for these postural distortions. For an example, following spinal subluxation, the first muscles to atrophy will be the smallest muscles in the body, typically the intrinsic muscles of the spine and the intrinsic muscles around the eye. If we have the recti muscles, which track the eye laterally and medially, if they're shortening, and now Claudette's eye tends to, during fatigue, lapse or list to one side, the head will rotate to keep her maintaining a horizontal plane line of vision. Or if the recti muscles, which drop the eye down and in, should weaken, the head will side tilt in an effort to maintain a horizontal plane line of vision. So the way we correct this is to use a Q-tip, and very carefully we're going to work the muscles in the following fashion. I'm going to first have Claudette look down as far as she can. The patient's eyes can be closed if they prefer. You're going to take a Q-tip, and you're not going to be pressing at a 90-degree angle into the eye. You're going to try to lay the Q-tip down as deep as you can get under the supraorbital ridge. You palpate back and forth for tenderness. Here we are using tenderness as our guide. If it's tender, I then ask the patient to look down even more, taking the muscle from a relatively short into a more lengthened position. We do this all the way in this fashion across the superior portion of the eye. We'll then do the same thing, having the patient look up along the infraorbital ridge. Again, I don't want to just gouge 90-degree angle into the eye. I go deep, and now I push up, and while resting the Q-tip on the undersurface of the eye, I rub back and forth, feeling for tenderness. If you notice where her eyes are looking, I will then ask her from this position to look even further up, slowly, and we'll do that several times. To get the muscles laterally and medially, we'll have her look first to the left. I'll take a Q-tip and I'll work the lateral 1/3 of the eye, the inferior portion, I'm going to work lateral to medial, A to P, until I can find the eye, push up superiorly, and then palpate for a lesion. Now, she's looking to the left. I will ask Claudette, once I've located a lesion by tenderness, I will ask her to look even further to that side. If I'm working the superior aspect, again, working the superior lateral 1/3, I'm going to go under the orbit of the eye. I'm pressing not only S to I, but lateral to medial. If it's tender, with Claudette looking to the left, I'll have her look even further to the left. We'll do the same thing on the medial aspect. I'll work the medial inferior portion and the medial superior portion, working above the infraorbital ridge, palpating for tenderness. She's going to look as far as she can to the right, in this case, laterally. Watch where her eye is. Now I'm going to ask her to look even further to the right as I make a contact into the scar tissue. And of course, I'll do the same thing here. I will go under the superior orbital ridge on top of the eye. She's looking to the right slightly. I contact the nail exposed muscle by going deep. It feels like it could be tender there, and I'll ask her to tap her to move her eye even further to the right. And that's the way we'll treat the ocular muscles. The treatment of the posterior cervical muscles is accomplished in the following manner. Recognize the fact that we have 4 deep layers of muscles to work through. So we want to have the patient's neck initially positioned in extension, and then we're going to move it into flexion. There's 3 areas we want to work. We want to work first lateral to medial into the lateral aspect of the spinous processes. We want to work centrally in the paravertebral gutter, specifically between the spinous processes and the transverse processes in this area here. And lastly, we want to work directly behind the transverse processes. So as I feel with her head in a neutral position, nose pointing towards the ceiling, upward for a restriction, if I find one like I do right there, I'll take a covered finger contact beneath the lesion as I passively move her neck from extension to flexion to the opposite side. This is very similar to the levator scap technique, only we're working through the trapezius, since this is one of the posterior cervical muscles. I will do 3 to 5 passes. I'm not gliding my fingers. I'm maintaining in one position with my fingers, hopefully. I will also do the same thing in between the spinuses and the transverse processes. We find a lesion right here. We position our finger beneath it. Hyperextender at that point. Press P to A, I to S, and then work the muscle in a lengthened fashion. Again, we go P to A, I to S, beneath the lesion, hyperextender over that point, and right there we begin to break the scar tissue up. And then lastly, we do the same thing behind the transverse processes. Here's a little bit of scar tissue here. We go beneath it, P to A, I to S, and we pull her head in flexion. Next, we're going to discuss the treatment of temporomandibular joint dysfunction, which is the 4th leading cause for presentation into a chiropractor's office. We need to recognize the fact that most people, 98% of the people with TMJ dysfunction, have the pathogenesis of the problem within the extra and intraoral muscles of the TMJ. Having said that, though, we need to recognize that 20 to 30% of these patients have a primary occlusal problem. 70 to 80% have a primary myofascial problem, which doesn't require co-care with a dentist, but 20 to 30% do. So it's important just to briefly discuss a few measures that will help us to determine if the patient needs to be shared with, hopefully, a neuromuscular dentist who has a good understanding of the myofascial tissues in this area. I look, first of all, for facial asymmetry. I look for a decreased vertical height of the lower third of the face, which Claudette does have. If we look at this portion of the face compared to this portion, this portion's lower. We may see a scrunched lower lip or a pouched lower lip, maybe some angular cheilitis in this area, some drool or some fissuring and cracking in this area from that type of a mouth posture. Inside the mouth, I'm looking at things such as, are the teeth overlapping in the front? Are they chipped? Are they cracked? Are they worn down? Do they lean towards the tongue? The teeth should actually be inclined 2 to 5 degrees away from the tongue. I look up into the mandibular vault, hoping to find, or the maxillary vault, hoping to find a dome-shaped vault rather than a sharp, angulated, cone-shaped vault. I'm looking to see if the posterior molars are also inclining towards the tongue, or whether they should incline as they should 2 to 5 degrees away from the tongue. I would take a rubber glove or a finger cot, and I would also palpate the teeth for mobility, which should not be present if there's good dental hygiene, and also I'm looking for missing teeth. We want to apply the diagnostic triad of ART, A standing for asymmetry of form and function, R for range of motion restrictions, and T for tissue texture abnormalities when diagnosing the TMJ patient. The asymmetry of form and function involves, again, looking at facial asymmetry, which we're going to come to in a second and treat through various cranial techniques. The asymmetry of function involves looking for what's known as mandibular torticollis. I will ask Claudette to very slowly open her mouth and examine the way her mouth tracks. Okay, now what happened with her, close your mouth again. We look at it during opening and closing, and do it again. As she opens her mouth, she has a very slight listing to the right side. We would list this as, or describe this as, right mandibular torticollis. The muscles that would cause that would be the ipsilateral medial pterygoid, the contralateral lateral pterygoid, and we would treat them accordingly. If she had range of motion restriction, which we would ask her to check for by taking 3 knuckles of her non-dominant hand, take 3 knuckles from your left hand.
My right is my non-dominant.
Oh, okay, right, 3 knuckles of your right hand. And put them in your mouth, if you can open them up. Vertically aligned. Vertically aligned, okay. And if she can do that, that's fine. If she can't do that, she has a positive 3-knuckle test and decreased interincisal opening. You put your hand to your side. The muscles that open the mouth principally are the lateral pterygoid muscles, and we would work those bilaterally. If she had mandibular torticollis as she was closing the mouth, going back to the previous procedure, if she's fine when she opens the mouth, but upon closing it, it deviates to one side, the muscles that close the mouth would be the temporalis and masseter. We would work those, and as well we would work the ipsilateral medial pterygoid and the contralateral lateral pterygoid. And then lastly, the T for tissue texture abnormality. We're palpating for fascial restrictions and then treating with a fascial release technique. We're going to now go ahead and do the procedure. I always start with checking the pelvis first because of its reciprocal relationship with the TMJ. I then work muscles that could refer into the TMJ, mimicking TMJ dysfunction, namely the upper thoracic muscles and the posterior cervical muscles, the deep anterior cervical muscles, and this is done over a period of time, perhaps maybe over 3 to 5 visits. And then I begin to work the extraoral muscles. I begin my extraoral technique by working the cranial fascia, which has a tensile strength of 4,000 pounds per square inch and sits like a shower cap on top of the head, going under the zygomatic arch and connecting to the superior portion of the mandible. If it's hypertonic, subsequent to a forceps delivery or a head trauma of some sort, it pulls up and inhibits opening of the mouth. So what I do, and I teach the patient to do this as a home exercise, is to grasp the hair, distract, and then torque clockwise and counterclockwise. If it feels more restricted as it does going clockwise, the patient will hold it for 10 seconds, increasing vascularity to the hair follicles and also to the fascia in that area. I will work the head in 4 bands: the occipital band, the posterior temporoparietal band, the anterior temporoparietal band, and then lastly the frontal area, which I would treat in the following manner using thumb contacts. Now right here, there's some tension. You can see the invagination of skin. The superficial fascia is tense. So I'll hold that for about 10 to 30 seconds until that begins to change. Right here we have even more tension, and then here even more. You don't want to just try to push through it. You want to hold it for the proper amount of time until it begins to release on its own. Now the patient's taught to do this as a home exercise, so really we're only doing it once and then perhaps checking them a second time. The extraoral muscles would be the masseters, temporalis, and the two pterygoid muscles. The masseter muscle has three portions. It has a vertical portion, which runs from the zygomatic arch to the angle of the jaw. It has an oblique portion, which runs from the zygoma of the maxilla obliquely to the angle of the jaw. And then lastly, a deep external portion, which runs on the inferior surface of the maxilla. If Claudette had difficulty with mandibular torticollis during the closing phase of opening and closing the mouth, I would palpate the masseter muscle in an I to S fashion. If I found restriction during this first strip, going I to S along the line from the zygomatic arch to the angle of the jaw, if I found a restriction, I'd position my finger beneath it, and I would ask her to go from, I'm sorry, open your mouth, please. I'd find it, and then I would position my hand above it, and then have her close her mouth against my resistance. Just like that. So what I'm doing, with the mouth closed, I'm palpating, feeling for restriction. I find some right there. I push S to I. Her mouth is going to be open, and I have her close again. The other hand, my left hand is simply supporting her jaw. I'm not pressing lateral to medial with any force into it. The second portion, if I find any restriction going I to S from the angle of the jaw to the zygoma, I'll simply lock into the scar tissue, have the patient open their mouth again, and then close against my contact. And I'm working an oblique line that runs like this. If I have any problem directly underneath the zygoma, like I do right here, again, the patient goes from an open mouth position to a closed mouth position. It should feel a little bit of a stretch locally as we work this muscle. Another muscle involved with mandibular torticollis during mouth closing is the temporalis. The temporalis has three portions that we can do actively. The first one will be the belly itself, which runs like it looks like a fan shape going above the zygomatic arch and below it to the temporoparietal suture. I palpate, feeling for restriction. I find some right about here. Of course, I'll palpate the entire muscle, but I find some right here. I'll ask the patient to open their mouth, and then I'll just simply press S to I and hold into the lesion as she closes her mouth. And again. We're using probably about 5 to 10 pounds of pressure. It's not a non-force technique by any means. Okay. Also, with the mouth open, if there was any restriction felt above the zygomatic arch, visualize the arch here and pretend we're trying to work underneath it. S to I and lateral to medial, and then also I to S and lateral to medial. If there's any restriction, with the mouth open, I'll apply pressure. In this case, S to I and lateral to medial. Open your mouth. And then go from open to closed mouth. Do it again, but slower. Okay, good. And then if we had a problem to treat here, we would do the same thing working I to S and lateral to medial as the patient opens her mouth and slowly closes it. The pterygoid muscles externally are treated in the following fashion. If the patient had a problem with deviation of the jaw to the right side, we want to work the ipsilateral medial pterygoid and the contralateral lateral pterygoid. The external medial pterygoid is found by palpating the angle of the jaw and using a contact that resembles a fish hook in the sense that you're going lateral to medial, I to S, and then medial to lateral. And the patient, if she's had problems deviating her jaw to the right, is going to start with the jaw deviated to the left. I'm sorry, deviate to the right. Let's deviate the jaw to the right. And then we're going to ask her to work it in a lengthened position by deviating her jaw now to the left. So she's going to go from the right to the left, as far to the left as you can. She's trying to go this way. It's a little hard to do. We'll do that again. Okay. The lateral pterygoid, which we would work on the contralateral side. So in this case, if I'm working on the right side, it would be for left mandibular torticollis. Externally, it's found by palpating the mandibular condyle. If you have trouble locating it, have the patient open and close her mouth a few times. Okay, that's good. And then an inch to an inch and a half anterior to it is the coronoid process of the mandible. We'll bisect our contacts and we'll find a soft indentation, which is the lateral pterygoid muscle externally. I push lateral to medial. The patient, in this case, will go from left lateral intrusion or left deviation to right deviation. So they go from a contralateral to an ipsilateral position. And again. Just like that. Okay. Next, we're going to do the intraoral muscles. Before we go on to the intraoral muscles, I just want to add that if the patient has decreased interincisal opening or they have a positive 3-knuckle test, we would want to release the lateral pterygoid muscles bilaterally to open the mouth up more. That combined with working the pelvis and also working the cranial fascia should be sufficient to make that correction. If not, perhaps there's some scar tissue, intracapsular scar tissue that would require joint manipulation of the TMJ. The first intraoral muscle we'll work will be the masseter muscle, which is involved in mandibular torticollis during closing. The patient will open their mouth. I'll take a gloved hand, hopefully with 3 protective layers of covering, such as a finger cot, 2 finger cots and a glove, or 2 gloves and a finger cot. As the mouth is open, I'm going to work first the vertical line from the arch of the zygoma to the angle of the jaw, also the oblique line that we worked previously outside the mouth, and then under the zygoma. I'm going to be palpating for anything that feels like scar tissue, like a BB or a little raisin, anything like that in there. And if I find anything, the patient will be instructed as I pinch lateral to medial and medial to lateral with my 2 fingers, bringing them together. The patient will be instructed to go from an open position, open your mouth as wide as possible, and then closed against my resistance. Okay? I'll do the same thing along that oblique strip. I find something right here, so I'll ask Claudette to open her mouth as I push into the lesion. And I'm actually pressing in an I to S fashion into the zygoma of the maxilla internally, and close your mouth. And my fingers obviously positioned lateral to the molars. And then last I'm going to work underneath the zygoma. And I find some scarring as I attempt to move under the zygoma. Right about here, but only interiorly. I'll press into it, and the patient will go from a full open position to a closed position. Much slower, much slower. Okay. The last portion, which is the deep internal masseter muscle, we find by taking our finger and placing it lateral to the lower molars. I then have the patient clench her teeth, and the muscle will tighten against my inner finger. Okay, right there I feel some scar tissue. I hold on to it, I have her open her mouth, and then to treat it, she will close her mouth very slowly. Open again, and then it's a slow closure. The temporalis muscle can only be treated in a very small fashion internally. Most of it we're treating when we do the extraoral muscles. If I had the patient open her mouth and deviate the jaw towards me, deviate your jaw towards me, this opens up a little pocket where we can reach. What we're attempting to do is find the condyle of the mandible, and our intention, while we can't really do this, our intention is to go above the condyle, behind it, and then medial to lateral. So I'm going I to S, I'm going A to P, going back, and then medial to lateral. Now right there, if there's any scarring, if you feel like when you push medial to lateral that it's stiff, the patient will be asked to go from an open position as wide as possible to a closed position. And again. Okay. The lateral pterygoid muscle is also treated simultaneously as we treat the newly discovered sphenomandibular muscle. We will take our fingers, our index finger, lateral to the upper molars as far as we can go posteriorly until we hit a dead end, and then we go I to S. We're now on both the sphenomandibular and the lateral pterygoid muscle. This muscle will be used to treat deviation of the jaw, in this case to the left side. I would have Claudette bring her jaw to the right as far as possible, and now deviate it right to left. This muscle is involved in contralateral. Go ahead, deviate your jaw to the right to left as far as you can. She can't move too much because my finger's there as a fulcrum. Okay, she's attempting to bring her shin in this fashion. Okay, the next muscle will be the medial pterygoid muscle. Patient opens her mouth, we take a finger inside the upper molars, and very carefully, touching the hard palate, we drop off into the soft palate. We then go I to S and medial to lateral against the medial pterygoid plate. The patient will bring the jaw to the right and then deviate the jaw to the left. This is involved with ipsilateral jaw deviation or mandibular torticollis. And we'll do it again. Bring your jaw to the right and then bring as far over to the left as possible. And that completes the intraoral TMJ work. We're going to now conclude our series of techniques of myofascial release by treating the cranial region. We're going to be doing an analysis that will involve looking to see if the patient has a high temporal bone. We can actually take Q-tips, or we can use craniometers if we have those, and look at the levels of the temporal bones by placing the Q-tips in the external auditory meatus and then pulling up. We're also going to be checking to see if one side's higher than the other. We'll do the same thing with the frontal bone by placing the Q-tips, pressing I to S on the inferior aspect of the supraorbital ridge. We'll also check the zygoma of the maxilla by pulling up under the zygoma, and then also finding the mandibular notch and doing the same thing for the mandible. Once we charted these lesions, we're looking for deviations I to S, S to I, and also anterior to posterior and posterior to anterior. Before we begin any cranial work, it's important to have done the cranial fascia, which we learned previously, and also the 6-step protocol for releasing dural tension. What we do for that is we'll start with the patient lying supine. The doctor will take his hands or her hands and first compress the craniosacral system as the patient now dorsiflexes her foot. This is held for 15 seconds and is repeated 3 times. And relax, we relax, then we do it a second time. This is done with the intention of actually shutting down flexion and extension motions of the cranial region, which agitates, in a sense, or stirs up craniosacral movement or respiration, making the system more active. And relax. And we do it a 3rd time. And then we're going to do decompression of the cranium. I'm going to reach underneath the occiput. I'll be pulling I to S, pulling this way as I take a hand and actually grasp a hair, and I'm pulling I to S. The patient will plantar flex the feet during this 3 times 15 seconds. And relax. And again, I'm pulling this way, I to S, as the patient plantar flexes the foot and holds for 15 seconds. And relax. Next, we'll do a decompression that's lateral to medial. I'll be pressing in lateral to medial gently with about 3 to 5 pounds of pressure on the zygomatic arch. The patient's legs will be bent, and she'll be instructed to push lateral to medial on the ASISs. The patient's going to push together the ASISs in this fashion. So I'm pushing lateral to medial, and so is the patient, 3 times 15 seconds. And relax. And push again. We're now creating motion in a bone that attaches to the maxilla and to the temporal bone. And relax. But also has a direct influence on the sphenoid bone, which connects to every bone in the cranial system with the exception of the nasal and lacrimal bones. And relax. Then we'll do decompression. I'll use the ears as a lever. I'll be pulling outward as the patient takes her hands and pushes medial to lateral. So you want to have your hands positioned. You're actually pulling the ASISs apart 3 times 15 seconds as we're doing this ear motion. I'm pulling laterally. Now I'm not pulling too hard. I'm probably utilizing 2 to 3 pounds of pressure here. And relax. And again. And relax. You could also, when you're doing pelvic assisted cranial motion, have a CA or receptionist do the pelvic movements to get even more force there. The 5th part of the 6-part dural release involves me taking the thumb and crooked index finger contact over the zygomatic arch, and I'm going to twist it into anterior rotation as the patient arches her back. She arches her back as I'm twisting in this fashion 3 times 15 seconds. And relax. We'll do it again. We're doing this mainly for the biomechanical lesions that we find, the superior and inferior and the posterior and anterior misalignments. And relax. And again. But we're also doing it for various symptoms as well. And relax again. The symptoms for pelvic assisted cranial work involve numerous pelvic complaints, especially dysmenorrhea and premenstrual syndrome, but also cranial problems such as headaches that are worse upon awakening, ringing in the ears, fullness or itching in the ears, TMJ pain, epilepsy, attention deficit disorder, learning disabilities of various kinds. The last part of the dural release is to take the same contact, but now I'm going to twist the zygomatic arch posteriorly in this fashion as the patient does a pelvic tilt or flattens her back. So she's flattening her back, I'm twisting in this fashion, holding it for 15 seconds with about good 5 to 10 pounds of pressure. I relax, she relaxes, and we do this again a second and a third time. Now, while we're doing the cranial work for biomechanical reasons, the first 6 parts, and then 2 other techniques, the sphenoid and the occipital release, which you'll see in a second, are really done to just reestablish some healthy motion in the cranial system before we start actually moving bones around. That completes a 6-step protocol for dural release. We're then going to move into the sphenoid release, and to do that, we simply find the zygomatic arch, we go superior into the soft area, the temporal region, and we're pushing medial to lateral, or lateral to medial on the right side, and I'll do the same thing on the opposite side, pressing lateral to medial. The side that feels softer is the side with better motion. The side that feels harder would be the side that's fixated. So in Claudette's case, it feels better when I press left to right, but when I press right to left, it feels rather restricted. So what I do is I press gently with one hand, lateral to medial, into the sphenoid bone, as Claudette will drop her knees to the right side, all the way to the table, and hold for 15 seconds. This opposes what I'm doing and creates greater stress, therapeutic stress, in this region, and we get a quicker and a longer lasting release. And relax. She brings her legs up, and she drops her knees down to the table, again to the right side. And remember, I'm pressing right to left. I'm pressing in this direction. Okay. And we would do that several times. The occipital release, the patient's not involved with any pelvic motions during this. What you're doing is simply lifting the head into a small degree of extension. You're taking the palms of your hands over the temporal region, and you're translating the head left and right, trying to release any scarring that may exist between the occipital and atlantal joint. If you imagine an axis going through her ears, like a pencil going through her ears, you're trying to translate the head along that axis. In other words, it's not a tilting, but a translation. Now, if it feels stuck, as it does when I go left to right, I'm going to have the patient try to push her head in the opposite direction. So Claudette, push your head to the left. She's moving this way as I'm pushing left to right. I'm pressing left to right. She's pushing right to left. We're holding for 15 seconds, and we repeat that 3 times. Okay, and relax. Now we would move on to our corrections. The corrections for the frontal, temporal, the maxilla, and the mandibular bones are really only done if the biomechanical analysis warrants it. For instance, with the frontal bone, which is usually where I start, if when we check the frontal bone by placing our Q-tips or our craniometers inferior to the supraorbital ridge, we found that one side was higher. What we tend to do is, rather than push the superior side down, which tends to create more compression, we take the low side and we're going to pull up. Now, as we pull up, this is important to notice. Pretend that in her case, the right side is inferior. What I'm going to do now, I'll take a thenar eminence contact. I'm going to place it in the frontal bone in this position, and as I pull up, I'm not pushing down on the opposite side, I'm just stabilizing. I'm going to ask the patient to drop their knees to the right side. Whatever side we're trying to lift, the patient will drop her knees to that side, always into the lesion. So I'm pulling up, I to S this way, perhaps slightly pushing S to I on this side, and having her drop her knees to the right side. And again, you can use a significant amount of force, up to 10 pounds of pressure. We hold that for 15 seconds. We do it 3 times. Relax. Back to neutral. Again, drop your knees to the right. Okay, and again. We're beginning to get some real nice motion in here. Okay, and then relax. If we had an anteriority or a posteriority, for instance, if when we looked in this plane, we found the frontal bone was rotated higher on the left side, rather than pushing the high side or the anterior side down, we're going to lift the posterior side. Again, trying to avoid creating compression, but actually putting decompression into the system. So I'll have a contact pressing lateral to medial into the lateral ridge above the supraorbital ridge. There's a little ridge here which is also referred to as a lateral orbital ridge. I'll be pressing lateral to medial and P to A, lifting it upward, again as the patient drops her knees to the same side. Just like that. Keep your head rotated towards the right. We hold that 3 times 15 seconds. Relax, go to neutral position. And again, I'm pressing this way, lateral to medial, P to A as the patient's dropping their knees to the opposite side. Okay, that's done 3 times 15 seconds. When we treat the temporal region, it's done very similar. If we have an I to S or an S to I lesion, for instance, if the left side is higher than the right side, I'm going to find the depression in the temporal bones and I'm going to lift up on it as I push the opposite side down gently at a ratio of about 1 to 3. 3 pounds of pressure pulling up for every 1 pound of pressure pulling down. I'm torquing in this fashion, and I'll have the patient again drop their knees to the same side, which creates some stress in the system against me, opposing me, which helps elicit a better and faster response. And again, I'm going to just show you the direction of my hands like this as she's torquing that way. Okay? If she had, for instance, an anterior or posterior problem, we're looking in the ears and we found that one side was higher, similar to the frontal bone. Rather than trying to take the high side, say it was the left side, and pushing it down, I'm taking the low side and pulling it up. So I get essentially the same area, but instead of pushing down, I'm going to be pushing lateral to medial. So again, drop your knees to the right side. This would be for a right posteriority. I'm trying to lift it upward. Again, now I'm just demonstrating the hand motions. In a second, I'll actually do it for real. We hold this for 15 seconds and relax. And if I did a real correction, go ahead and do it again. It'll look something like this. Now, it's common for the patient to feel a little woozy when they get off the table because we've stimulated a lot of mechanoreceptors that are found within the cranial sutures. So it's important to make sure the patient rests after this is done. Now we're going to conclude with 2 intra-oral cranial techniques, treatment of the mandible and the maxilla. We'll do the maxilla first. If the patient had, upon examination with the Q-tips or the craniometers, one side that was higher, for instance the left side, we're going to take the inferior side and we're going to lift it higher rather than pushing the high side down. If we're working the right side, I'll have a finger contact or a dual finger contact under the maxilla, and I'm pulling I to S. At the same time, the patient's mouth is open. You use a gloved hand, and I'll have a thumb on top of the molars. Now, I'm not going to try to exert too much stress on the mandible in this position, but I'm just gently, with about a pound of pressure at the most, applying a counterforce while I'm at the same time lifting up I to S under the zygoma. At the same time, on the side that we're trying to affect, the patient will drop her knees. So we'll begin by having her drop her knees to the right. I slightly apply a downward force on the molars as I'm pulling up on the zygoma for 15 seconds. Do it again. Relax. Okay. And again, I'm pulling up this way as I'm applying a very slight counterforce on the mandible. And again, now of course it's done slower, 15 seconds. I'm pulling up with about 5 to 10 pounds of pressure under the zygoma. I hold it for a full 15 seconds before I release. Okay. If the problem that I actually had was we had an anteriority instead of an inferiority, and you can have both, and we would treat both. But say the principal lesion here was that she had anterior lesion on the right side and the left side was posterior. The maxilla was in a sense like this, independent of the rest of the head. What I'll do now is I'll have the patient open her mouth. I'm taking an index finger contact inside the molars, upper molars, and I'm going to be attempting to hook, like a fish hook, and lift her in this fashion. The left side posterior to anterior, while I gently apply a counterforce, P to A, on the zygoma in this direction. This is the side of involvement, so the patient now will bring her legs to the left side of the table. I'm pulling down on the zygoma this way, gently, a ratio of 3 to 1, 1 pound here, probably 3 pounds pulling up here, and relax. And again, I'm pulling upward in this fashion against the upper molars while I'm pulling downward slightly on the zygoma on the opposite side. Let's do it one more time, put it all together. And that's held for 15 seconds, and that would be the treatment for the maxilla. And relax. If when checking the mandible and the mandibular notch, we found that one side was higher than the other, the patient opens her mouth slightly. Say the right side had been higher. Rather than pushing it down, we're going to take the lower right side and we're going to lift it up. Now this may seem a little unusual because as we lift it up, relax your jaw, there's really nothing to resist us. So what we're going to do, we're going to create a fulcrum on this side. Okay, open your mouth. I'm just going to take a protective barrier. I'm going to use my thumb to act as a fulcrum. When she tries to close her mouth now, this side on the right stays stationary, and the left side begins to raise. Plus I'm going to have a contact like this. The principal contact will be underneath the mandible as I try to lift it in a superiorward fashion, and she drops her legs to the left side. Just like that. Let's try that again. Now, again, it's slower. I'll be pressing down, S to I, on the mandible, like this, as I pull up, I to S, on this side. Okay, let's do it for real. We'll put all the pieces together and do it gently. Very gently, with about 1 pound to 2 pounds of pressure, pushing down on the right mandible as I'm pulling up with about 5 to 6 pounds on the mandible on the inferior side. Okay. If she had an anterior or posterior lesion, say for instance we had a lesion that was anterior on this side, we checked the mandible and we find that it's torsion in this fashion, higher or closer to the ceiling on the right side, rather than trying to push it down, I'm going to lift the left side, which is inferior, in this fashion. We're going to try to lift it up. So open the mouth again. The contact is a thumb on the upper molars. My fingers are underneath the mandible, and I'm attempting to pull the mandible in this fashion, P to A and lateral to medial towards the right, as I take a contact on the right side and traction it downward. The left side is the involved side, so the patient will drop her knees to the left. We'll hold that for 15 seconds. Let's do each part individually. Go to a neutral position. Okay. And I'm pulling, go ahead, drop to the left. I'm pulling with this hand in this fashion, P to A, lateral to medial, while I'm treating in this fashion on the mandible, on the right side. And again, let's do it all together. We'll look like this. The principal force, as she drops her knees to the left, is on the left side. Let me do that 3 times 15 seconds. And that would conclude our cranial work. In conclusion, I would like to urge you to practice this material as oftentimes as possible. It's not difficult material to learn, it just requires a little bit of hands-on practice. I urge you to take the material and learn it in 2 different ways. Feel free to take an individual routine and use it as an isolated entity. For instance, if a patient has deep anterior shoulder pain, employ the infraspinatus technique, or if a person has dysmenorrhea or vertical low back pain, utilize the psoas routine. Also, and very importantly, learn the biomechanical rationale behind this work as we presented it on tape 1, and learn the sequence of treatment for biomechanical problems and postural distortions, and treat those. Start with the pelvis and go through the sequence we follow, and I think you'll get very satisfying results. It's also important to take the patient and to neuromuscularly re-educate them by utilizing techniques such as ankle boards, gym balls, wobble boards and wobble seats for the ankles and the pelvis, as well as cervical extension and the rib extension exercises we utilized earlier for the treatment of hyperlordosis of the cervical spine. It's important also to recognize the presence of perpetuating factors. These are anything that, if left untreated, will perpetuate the patient's problem. Dr. Janet Travell has written an excellent chapter in her Volume 1 textbook, Myofascial Pain and Dysfunction, Chapter 4. She lists about 120 plus different perpetuating factors that are common in the myofascial patient. Things such as hypoglycemia, hypothyroidism, anemia, gout, short legs, small hemipelvises, various postural problems, nutritional inadequacies. If we don't recognize these factors and treat the patient, our work will be short-lived at best. Also, it's important to recognize the importance of nutrition in treating the myofascial pain patient. The patient must be taking an adequate amount of antioxidant nutrients, otherwise free radicals proliferate in the body and actually cause direct damage to muscle cells. And then lastly, if a patient's eating a lot of red meat, shellfish, fried foods, foods that aren't healthy anyway, what they contain are arachidonic acid in quite large amounts, which are precursors to prostaglandin E2, which are highly irritative, nociceptive irritants. If the patient's eating large amounts of these foods, it will actually irritate and perpetuate the pain, spasm, scar tissue cycle. In closing, I just want to say thank you for purchasing these videos, and I hope the information will be very valuable to you in your practice.